Good morning, sir. Today I'll be presenting a case of Mrs. Rihana. She is a 29-year-old female resident of Ajmer, Rajasthan. She is educated till 7th standard and housewife by occupation. This history was given by the patient herself and her husband and is reliable, sir. So she presented with a history of progressive dysphagia to food following ingestion of a toilet cleaner, Harpic 2 months back, sir. That is on 19th of September 2021, sir. So patient was apparently asymptomatic 2 months back. When she gives a history of ingestion of toilet cleaner 2 months back with a suicidal intent, there is a history of vomiting immediately after the ingestion, and the vomitus contained clear yellowish fluid, large amount, non-projectile. She gives a history of difficulty in speaking and change in voice, which improved after a few days on its own. Uh, sh- she was immediately taken to a primary health center nearby, where vomiting was induced by giving some syrup. She then had multiple episodes of vomiting with blackish colored vomitus. She was then taken to Ajmer government hospital on the same day, where she was managed conservatively with IV fluids and medications, and her vomiting subsided after a few days. Subsequently, she underwent contrast study and two upper GI endoscopies at the same center, and she was started on oral liquids after 3 days of hospitalization and was gradually shifted onto semi-solid diet and discharged after 7 days of hospitalization. After discharge, patient complained of discomfort while swallowing semi-solid with sensation of food sticking at the mid-chest level, and this dysphagia progressed over next 15 days when she was finally unable to take any semi-solid and was able to take only liquid in small amount. Patient was referred to this center with history of taking small amount of liquid at a time and inability to take semi-solids. So in the past, patient gives no history of there's no history of diabetes mellitus, hypertension, pulmonary coughs. Uh, uh, Patient is a non-smoker. She is a non-alcoholic and denies any addiction in any form. There is no history of blood transfusion on high or high-risk behavior. In the treatment history, patient is a known case of depressive disorder since 1.5 years, and was prescribed some oral medications, which she took for 6 months with symptomatic improvement in her condition. These medications were stopped on her when she became pregnant with her fourth child. She delivered a healthy baby 3 months back. However, these medications were not resumed after delivery. There is no other relevant treatment history given by the patient, and there is no history of any surgery in the past. She is a para 5, A1, L4, and she had a normal menstrual cycle and no other menstrual history. On summarizing the history, she is a 29-year-old female, known case of depressive disorder, not on regular medications, and presented with a history of consuming corrosive with suicidal intent 2 months back, with a history of induced vomiting with multiple upper GI endoscopies at a nearby hospital, and a history of progressive dysphagia from grade 3 to grade 4 over 2 months' time.
Fine. So now, how do you interpret this history? Interpret and analyze it.
Sir, patient gives history of having taken acid corrosive, sir, with suicidal intent, and uh, 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 this was an acid corrosive injury, sir. She was initially taken to a primary health setup where vomiting was induced, which probably resulted in aggravation of the injury that she had, and this resulted in a progressive dysphagia. The scarring process would have led to worsening of her symptoms over the next 15 days.
So, if you get this sort of history, what additional information you would like to seek from the patient?
Sir, I would like to know if she had any. Uh, I would like to rule out if she had any oropharyngeal uh, injury also. and that would be clear if there is a history of drooling of saliva
You
or
can shut the slide for some time till you can
uh,
stop the presentation. Yeah, continue now.
sir, if she gives a history of drooling of saliva, change of voice, stridor, then then we can assume that she also had a history of oropharyngeal injury.
No,
And
any other thing. You see, what I was trying to emphasize is that whether you would like this patient, the patient has undergone many endoscopies, you said.
yes, sir.
So, would you like to know when the endoscopies was done, the first endoscopy duration? Why you'd like to know, and
Sir,
how
the
will you get
first
the findings from the patient? Why you are interested in getting the findings from the patient?
sir, the first endoscopy was done 3 days after the ingestion of corrosive, and I would like to know the finding of endoscopy because she was subsequently her subsequent management will depend upon the findings of her initial endoscopy. This initial endoscopy will also give me will help me in prognosticating the patient as to the further course that she might
Fine. So,
have
do you
to
have the findings of the endoscopy?
Yes, sir, I have.
Can we just project the findings? Is it alright that the endoscopy was done on the third day?
Yes, sir, it was
The date
all
is
right.
there. Huh? Endoscopy
Yes, sir,
date is there.
it is there. Sir.
Okay. What is a good time to do endoscopy if a patient has had ingestion
Sir,
of corrosive?
sir, within 72 hours, it is advisable to do upper GI endoscopy. Some endoscopists prefer doing it within 24 hours, but there is another group which feels that between 24 to 72 hours is the ideal time for doing endoscopy, sir.
Why early endoscopy? Why not after 50 or 7 day?
So because the esophagus, because from 5 to 15 days is the granulation phase of the injury when the tissues are weakest. So at that time, if an endoscopy is performed, it will lead
No,
to
is that the reason or there is some other reason? Granulation actually is good. You see, if it is granulation indicates healing. So if there is healing,
but sir,
endoscopy should not be a problem.
but the tensile strength of the tissues is the weakest during the granulation phase of the healing process.
Any other reason more important than that? That if you do a little delayed endoscopy, there is a risk of perforation.
Yes, sir.
What is the reason for that? Are you supposed to answer or others also can answer? If you have difficulty. Anybody else is there, they can also answer and put the reply into the chat box. I'll wait for a few seconds, otherwise I'll give the answer. Would you like to try any other answer for that?
Sir,
Apart from what you said.
sir, it will help
Yeah.
us guiding the patient whether, sir, if we can, if we know the quantum of damage that has happened, we will.
No, I'm not asking why we are doing endoscopy. I'm asking the duration. The duration means within early and intermediate.
Sir, too early, that is within 24 hours, has got the disadvantage that uh, even a hyperemia of the esophagus, mild injuries can be misinterpreted as a grievous injury. So within 24 hours, the initial signs of inflammation like erythema, uh, erythema or
But as
edema
you
will
said, there
subside.
are people who do early endoscopy also, but it's fine. I accept that what you said. But basically, what happens is that when you have ingestion of corrosive and there is a corrosive injury, there is a possibility that after few days it can lead to transmural injury. So when there is a transmural injury, that is at the highest risk of perforation. Because when you do endoscopy, what leads to perforation?
Sir, it is
What
the
it is
it is
the
the it is the passage of endoscope, rigid
no,
endoscope.
very rarely, not passage of endoscope. It's something else.
So it is a necrosis of the tissues which.
No, it is the insufflation of air. That is why when we do endoscopy for corrosives, we always put low pressure air. It is insufflation of air that can actually lead to a perforation. Manipulation by scope is another reason. not insufflation. You see, when you put it into the stomach, the scope is not going to touch the walls of the stomach. But when you insufflate, the transmural injury can become complete injury and you can have a risk of perforation. That is why a little later it should not be done. If you have to do later, then it should be done.
So after 15 days, sir.
Yeah, after 2 weeks, 3 weeks, it's fine. Then you can do endoscopy at that point of time. So here you're saying this is the third day endoscopy.
Yes.
So what are the findings? What is the interpretation from this report?
Sir, the report is suggestive of a grade 2B or a 3A.
What is written there? I can't tell. Fundus, what is written there? What is the first word? What is that? B. It starts with B.
Sir, actually, it's not very
black pigmentation.
Black pigmentation, it says, yes.
Yeah, black pigmentation, the fundus.
And then hyperemia, sir. And esophagus is superficial ulcerations with white exudate and exfoliation of mucosa.
Superficial ulceration with white exudate, exfoliation of mucosa. Okay. So what is the interpretation from this?
Sir, it could be a grade 2B injury or more, sir.
Why do you say that?
Oh, sir, although 2B is suggestive of, according to the Zerger classification, it is a circumferential ulceration, which comprises of grade 2B. It doesn't actually specify whether it is circumferential or it's a patchy superficial ulceration. But
fine, agreed with that. So of these findings, 3 findings are mentioned here, is it not? Duodenum, yes, they have said not assessed.
Yes.
So do you think they should have put the scope in the duodenum?
Yes, so they should have tried to.
They should have.
Okay. Yes.
So it's only hyperemia of the body and the antrum. When will you not be able to go into the duodenum?
So when there is intense pyloric spasm because of the corrosive ingestion.
Edema, basically. Edema. Third day, na? Is it not? Yes, not be spasm, but edema, and you might not be able to. Then you should not force into the duodenum. Okay.
Yes.
When it comes to the stomach, what is the commonest site where the injury happens? And
so
why?
So commonest, it happens. It depends upon whether the patient is empty stomach at the time of corrosive ingestion or she had prior food, sir. Okay. If the patient is empty stomach, the most common site is prepyloric region, sir.
Why?
So because of the stagnation of acid predominant in that region, sir. Because the pylorus undergoes spasm and edema, so there is a prepyloric stagnation of fluid.
No, edema will not happen. Okay, see, if a person ingests acid, okay, it will take how long? 1 or 2 minutes, is it not?
Yes, yes. Sir.
So not going to drink acid like water, is it not? One time only, few minutes only.
Yes, sir.
So will that time be enough to produce edema of the pylorus? No, no, it's not. So it's the spasm. Sure. So when the acid goes down, it produces pyloric spasm, and that leads to the collection of the acid primarily in the prepyloric region. That is the commonest site where it stagnates and leads to injury. Yes. So that leads to 2 things. So when it leads to a prepyloric injury, what is the second thing it leads to? Pyloric spasm. What is the second thing it lead to? It will lead to protection of the duodenum. Is it not? So the acid will not go into the duodenum. So that is why most of the time duodenal injury is very rare. Okay, with hypercorrosives. It is the esophagus and the stomach.
Yes.
So here, that's why I said they should have gone to the duodenum, and most likely duodenum would have been fine in this particular patient.
Yes.
All right?
Yes.
So before you do endoscopy, now let's say this is the 3rd day, you are assessing, you are the treating clinician. What clinical examination and additional examination you will do so as to before carrying out endoscopy?
So in the acute phase, when the patient presents to us first, we would like to first assess the patient for his or her hemodynamic stability, and would like to assess the airway, breathing and circulation of the patient in the lines of, as we would do in any patient of...
this is not a road traffic accident. No? It's just an injection of this thing, corrosive. Why it should lead to hemodynamic instability?
Sir, her airway could be compromised because of the coexisting oropharyngeal injury. She could have respiratory distress, stridor, So that is
Why?
what
Why?
happened.
What will lead to respiratory injury in a patient? You
Sir,
said this
edema
was
of,
this was suicidal, is it not?
yes,
So, in a patient who is taking corrosive with a suicidal intent, what is the other way they take? What is the other way, other modality of ingestion?
sir, accidental, sir.
Accident. In which the oropharyngeal injury or the respiratory injury more common, and why?
Sir, in suicidal, it is more common, sir,
Why? Why?
because patient is aware of what he or she is taking, and
Mhm.
they are initially reluctant, so they tend to keep the corrosive more for a more period of time
Very,
in their
very good answer.
oropharynx.
Yes, hesitancy is there, is it not?
Hesitant.
Hesitancy, they might sometimes try to spill out.
Yes,
So all those things can lead to extensive injury in the oral. Where if a person takes accidentally, there's no question, is it not? They just swallow it off.
yes,
So the more less chances of upper aerodigestive tract injury. That is what is likely. So this is suicidal. So there is a possibility that there could be more of injury, and that is why you said respiratory problem can happen. Okay.
yes,
Hemodynamic, little unlikely. Okay. Hemodynamic instability, if a patient has following corrosive injury, what do you suspect?
sir.
The blood loss doesn't happen no, with
No,
corrosives.
sir, it will not. But
Hmm.
patient can have transmural injury and can land up with perforation
Yes,
of the
perforation.
esophagus or stomach. Yes,
Esophagus or stomach.
yes,
Perforation can happen. So that can lead to hemodynamic instability in 2 to 3 days. All right.
yes.
So how will you assess that?
Sir, serial clinical examination of the patient, and we'll look for
So
signs of
that is a contraindication for endoscopy. Is it?
endoscopy.
That's why I wanted
Yes,
to bring that point out. Before you do endoscopy, we should look for that. One is the abdominal signs. What other signs the patient can have? Physical signs.
sir. If the patient has esophageal perforation, she will have signs of mediastinitis, sir.
What else? If a patient has many times while doing endoscopy, you produce a nitrogenic perforation of the esophagus. Apart from mediastinitis takes time to happen.
Yes, sir.
What happens first? You can make out there's a perforation. It's an innocuous sign, but it's a very important sign. The air leaks in the subcutaneous tissue, what do you call it as?
Uh, emphysema, sir. It
Emphysema.
will
Where
be,
we look for it?
sir, in the chest wall, sir.
Chest wall,
In
not
the
so
neck, sir.
common.
In the neck, sir.
Neck, axilla, that
Neck
area.
and axilla.
Okay.
Yes, yes,
So that is where it can happen. So you should look for that. If that is there, then it indicates air leak. And as you said, abdominal signs are there. Okay, in those circumstances, it's contraindicated. Okay.
yes.
So these are the endoscopy findings. So you feel that this patient is likely to progress with severe progressive injury or no?
Sir, I feel she is likely to progress.
What findings you have mentioned in endoscopy here?
So generally, sir, if a circumferential injury, circumferential
No. We're not
ulceration
going
is
into
seen,
that. You see, the report is there in front of you. So
sir.
what points in this report indicate that there is likelihood of progressive injury? See, it can be progressive or after 1 week, you do the endoscopy, everything is fine inside. Is it not?
Yes, sir.
So what findings on this report suggest that there is a possibility of this? That's what
So
I'm
there is
asking.
ulceration with exudate.
Exudate, yes. So only thing that is in favor of the patient is superficial. It's not even deep. Is it not?
Yes, yes,
And the black pigmentation. Black pigmentation is not a good sign. Okay, that is what is written there. Black pigmentation. So you don't know whether there is a deep injury to the stomach. That's in the fundus. All right.
yes, yes.
So if you have done this endoscopy, you have seen this report, third day, what will be our next step? See, we have to go for management of corrosive stricture. That's a topic for today. So we'll shift to that very soon before we tackle this acute injury. So this is the finding in front of you. What next in this particular patient?
Sir, we'll keep the patient NBM for 3 or 4 days. We will start her on proton pump inhibitors. We will give her broad spectrum antibiotics during initial few days, and gradually start oral sips. Ask the patient to start taking oral sips and see how she tolerates it. If she tolerates oral sips, we will gradually increase the amount of liquid, and uh, we'll try and in a couple of days, if she is able to take liquids completely, then we'll try and shift her to semi-solid diets. During the initial phase,
Okay, let me interrupt you. Will you do another endoscopy? That's my question. And when?
sir, another endoscopy we would like to do after 15 days, because by then the strictures would start developing, sir, by third week. So we would see if the strictures if they start developing, we can we can advise for endoscopic dilatation after
No,
3 weeks.
no. That is very much later. Okay. So at 15 days, you will do endoscopy to find out the assessment of this. Now, see, this is a borderline injury. That is why this dilemma is there. If the injury is such that is only hyperemia seen and very superficial ulcer, then what you said is fine that you will start the patient on orals and then gradually see and do one check endoscopy 2-3 weeks later. Is it not?
Yes.
But if the injury was more severe, you have severe congestion, edema in the stomach, and you have more deeper ulcerations in the esophagus, then what will you do? You have 4-5 places black pigmentation in the esophagus also, inside the stomach also. There is edema of the stomach also. You are not able to enter the pylorus through the pylorus into the duodenum. Then how the management will change?
Sir, actually, we have to look whether the patient is able to uh, take enteral nutrition or not. So we have to assess that. Earlier, sir, there was a uh, so earlier there was a Riles tube was advised, sir, but presently it seems that it's not clear whether Riles tube should be inserted or not, because there are reports which say that if Riles tube is
Okay,
inserted,
that is fine. That's fine. What was the use of putting a rice tube? Was it for feeding or something else?
so for subsequent dilatation of
Yes. So you have a tract.
over the
You
arteries.
have a
Yes,
tract. Okay, you
yes,
a tract is formed through which you can pass a guide wire and can help in dilatation. That was the primary aim. But
yes.
sometimes putting when you have severe injury, okay, so putting a rice tube also can be risky. I agree with you.
Yes.
So what will you do then?
Sir, if the patient is able to take after 2 or 3 weeks, if the patient is able to take liquid or a
No.
semi-solid
Say
diet,
2-3 weeks you have gone further. Na? What will you do? You say 2 days, third day you have done endoscopy, and that's the finding. I'm asking fourth, fifth, sixth day, what will you do?
so we'll ask the patient to take liquids.
See,
And
severe injury, I said there is pyloric edema. Still, you'll ask the patient to take liquids. See, here the injury is borderline. So I accepted what you said. If the injury is severe, what will you do? It can be severe
so
also.
we will
No. See, starting the patient on liquid in severe injuries can lead to perforation.
so we can start parenteral nutrition for the patients.
Yes, first you can start the patient on IV fluids. Keep the thing. Keep a close watch on the patient for any perforation, any acute injury
Yes.
to the esophagus of this, and then after subsequently, if the patient is fit and fine, then you can consider doing a subsequent endoscopy. Unless and until you do endoscopy, you can evaluate. You can't evaluate the injury, is it not?
Yes.
Now you have done endoscopy, let's say after 2 weeks, and the injury it has progressed more. Then what will you do? The edema has become like you just can't go through the pylorus of the duodenum. What will you do then? You have done endoscopy at 15 days. See, the edema does not subside; it becomes more, and you will find that edema which is there in the esophagus, the ulcerations, okay, they are coalesced, and same thing is there in the stomach. Okay, except for the fundus, the rest of the stomach is very edematous, and you have the beefy mucosa, and then you have ulcerations and edema. So what will you do now?
So we can
You got my
create
point?
a
Yeah.
yes, sir. Sir, even if this does not improve after 3 or 4 weeks,
No, see, I've told you now, 15 days endoscopy. You have done the 15 day, you said 15 days, I agree. But you have done on 16 day endoscopy from the third day. Okay, so you can add it 12 or 13 days plus. And these are the findings.
so we can create a fitting jejunectomy for the patient.
Yes, that should be the answer, is it not?
Yes.
So after 15 days, if the injury is progressive and all, now you have to create an enteral access. You can't keep, this is going to be a long-standing thing now, so you can't put the patient on whether it is an parenteral or IV fluids. Is it not? So you have to plan endoscopy. So you'll do a FJ in this patient. Alright?
Yes.
That is how you'll have to manage. If things are fine, what you said is all right. You start the patient orals, wait and watch policy, do a repeat endoscopy, and if things are not fine, it can be either way. If it is just grade 1 injury, only hyperemia and all that is there, you can start the liquid same day evening itself. Is it not? And
Yes.
2 days later, you discharge the patient, and you need not call the patient after 15 days for endoscopy also.
Yes.
You can tell the patient SOS if any problem is there, please come. Otherwise, you can just discharge the patient and do an endoscopy after 2 months SOS. Okay, just as a check.
Yes.
So that's how we'll do it. So this is a little bit of the management of acute injury. Okay, so you
Yes.
proceed now. You said many endoscopies were done, na? So you have any other report after this?
Sir, in the same center, a second endoscopy was done, sir.
Hmm.
But this was done 6 weeks.
6 weeks later. Okay, we'll see later then.
Yes.
Okay, you proceed
Yes.
now. So any questions anybody has before we proceed further for examination? Do you have, Siddharth, any questions?
No, sir.
Okay. Any other question anybody has can ask orally or put in chat, whatever way you can put it. Fine, proceed.
Sir, on examination, patient is averagely built and poorly nourished, and she's lying comfortably in the bed.
Okay, there's a question. Okay, can you answer that? What is the timing of endoscopy in severe grade injury?
The initial endoscopy has to be done within 72 hours, sir.
Yes. And then later?
And later, after 2
I think
weeks,
probably wants to know more about FJ. Rather, endoscopy we already discussed. So when will you do the FJ?
sir, after waiting for 2 weeks, on a second endoscopy, if we find that the grading of injury is more, and she's unlikely to be on a enteral nutrition in the near future, or oral nutrition, we would like to create a portal for
Very good, very good answer. Okay, so you'll see two things. Okay, one is the status of the injury. You said if it is progressive, it is like from grade 3 will become grade 4. That is when you'll do FJ, or it is static also. Then also you will do FJ. But if you find that your initial judgment, okay, whatever it was, that ulcerations, everything, it is now healing well. In those circumstances, then you will not do FJ. Is it not? You will wait and
Yes,
watch them. Is it not? One more week you wait. Put the
Yes.
patient in parental nutrition. Again do endoscopy and see if things are better, you avoid FJ. Okay, so that is how will the plan be. Is it okay, Dr. Agarwal? Any other question? Any other follow-up question? Fine. Okay, so please carry on.
Sir, I would like to ask whether CT scan is indicated in the initial evaluation, because I was going through a few articles. CT has recently been reported to be being used if endoscopy is contraindicated in any way. If you are suspecting a transmural injury and endoscopy is not indicated in, or in children who wear
No,
endoscopy.
the thing is that CT will be required for the assessment of acute injury, perforation, all those things we can always do. Mediastinitis, all those things will be detected with CT. But if the patient is all right, there should be no reason that you are not able to do endoscopy.
So if there is no perforation, there is no indication for CT scan. Sir. If you are not suspecting perforation.
No. There's no indication of CT scan. Okay, endoscopy is the gold standard for the assessment in the early phase. You do the endoscopy. If the patient is symptomatic, the patient says there is severe retrosternal pain, and patient says there is abdominal pain. Usually, these patients come with in an asymptomatic mode, is it not? They will just have little bit of. They won't have much of tenderness or abdominal pain or chest pain. All those things are not much, even if the injury is there. Okay, so they will just say this sort of history is there, and then you ask the patient. You carry out endoscopy because that will give you a clear cut injury status to the upper. This tract, aerodigestive tract, aerodigestive both. When we do endoscopy, we also look at the cords. It is visible. Okay, so we can see that things are fine there. We look at the oropharynx, that there is no congestion, nothing is there, all those things, and then proceed. Okay. Upper GI contrast study, no, I don't think right now in the contrast study, we'll see little later, but not now. Okay, we are right now in the initial phase. Should middle colic artery be ligated during FJ for the development of good collaterals? No, I am not very sure. if somebody does it, but routinely no. One thing, okay, since you mentioned that point of FJ, what precaution you should take when you do FJ in this patient? If you have to do FJ. Somebody's mic is on. Can you just shut the mic off? Mic is on. Okay, can you tell these two people the mic is on? Vishnu and Rajendra. Causing disturbance. Somebody please tell them. Okay, so yeah.
Sir, sir, there is a possibility that
Dr. Vishnu, Dr. Rajendra, can you shut off your this thing, please? It's causing disturbance. 2, 3 are open. Yeah, thank you. Yeah, please continue.
So since there is a possibility that there is a concomitant gastric injury also, so we might have to use use jejunum for our bypass, subsequent bypass.
No. Jejunum is very rarely used. Okay, it's a simple answer. Simple answer. Okay, simple question, simple answer. I'll tell you the answer. Yeah. Answer is without disturbing the abdomen. Okay, too much, especially the supracolic compartment. Okay, do a F shape. Okay, so that is what is very important. We should not disturb anything anywhere too much. Of handling also should not be. We just do FJ beyond the DJ flexure and nicely fix it, because the FJ is going to be there for months to come. So that is what we do. So that should be the aim. Without much of disturbance, we do the FJ. Because somebody mentioned about ligation and middle colic, and also we have never done that, but if it is mentioned somewhere, maybe some advantages there. Okay, so the case of fistula. Okay, so there is another question. Can you address that? If there is a severe injury and management of tracheoesophageal fistula, then what will you do? There is the formation of a tracheoesophageal fistula due to the injury.
Sir, in the acute phase, sir, if it is a proximal tracheoesophageal fistula, patient can be on and the patient is hemodynamically unstable. We can protect the airway by either elective intubation and later on to secure the airway, sir, during the initial phase.
Okay. Any other way? Is there a role for stenting? The removable stent, polyflex.
So there is, but during the late phase, during the initial injury, during the first 15 days, doing a esophageal stenting will be counterproductive, sir.
I agree with you. Okay, so in the initial phase, actually tracheoesophageal fistula will not happen in the initial. It will take time. Okay, so if there is a transmural perforation and injury, when you see it on the 3rd day, 4th day, 5th day, something like that, okay, then you have to appropriately manage. If there is a perforation, esophageal perforation, what will you do? 3rd day you find, or 2nd day itself. Then
so we can do a damage control surgery, sir. We can esophagostomy, sir, will staple the distal end, will take out the proximal end as
yes, esophagostomy has to be done, and then if it is possible to resect. Otherwise, in those circumstances, not possible. Patient's condition doesn't put good drains and good drainage, is it not? That is what you have to do, and you'll have to put FJ for the thing.
Yes.
So that is what you said is we'll have to do surgery at the minimal level, which is maximally useful for the patient. Alright,
yes.
So that is what we do. So I think if we go too much into acute, then we'll not be able to discuss corrosive stricture. Okay, we are running short of time. Sorry, 9:40. So I think we'll proceed right now. We'll not take too many questions of acute. Okay, otherwise that will get left out. Okay.
Yes, sir.
Yeah, tell me.
Sir, in the general physical examination, the patient's nutritional status is not adequate, sir. Her BMI is 16.5 kilogram per meter square. Otherwise, her vitals were.
Why do you think this happened?
So it's because of 2 months since injury. She has not been taking orally in a in adequate amount.
So the answer is that FJ was not put, is it not? At some point of time, is it?
Yes.
Not? FJ was not put initially. Also, it was not put. Later on, things became bad. Patient did not come probably, or patient kept on shifting the hospitals, whatever the reason. Okay, so nutrition was not maintained. The patient was gradually, the patient's intake became progressively low. No? Is it not?
Yes, sir.
So that is the reason that it has DMA has gone down. Okay,
sir.
Proceed.
Sir, otherwise in the systemic examination, sir, abdomen, sir, there was no significant finding in the during inspection and palpation, sir.
Yeah, and this is what usually we expect, is it not?
Yes,
usually,
yes, sir. Yes.
There will be nothing there. Okay.
And chest and other systemic examinations were also within normal limits, sir. Sir, after history and examination, sir, after examination, there was no other, there's nothing to add, sir, except that the patient's nutritional status was poor, sir, with a poor BMI. And otherwise, no
okay, now I think it's a time to, because you're seeing the patient at 2 months. No? This is 2 months now. No?
Yes, sir. Yes, sir. It
so
is.
You can now show the endoscopy reports and see. We'll see what is the status right now.
So this was done at our center, sir.
At 2 months, is it not 8 weeks?
Yes, yes, sir. It is 2 months, sir.
It's, can you read? It's very small. Okay, so.
Sir, esophagus. This was. It shows a narrowing just below upper esophageal sphincter, sir, at 18 centimeter from central incisors with friable mucosa, through which scope could be negotiated with slight difficulty. Another narrowing at 30 centimeter and a web at lower end, but scope could be passed easily through these narrowings. In the stomach is contracted with friable mucosa, along with superficial ulcerations and many divertically like outpouchings. Pylorus was narrowed with difficulty in passage of scope. Cannula passed across the pylorus into duodenum under fluoroscopic guidance and contrast injected into duodenum. Subsequently, long stricture also noted fluoroscopically in the duodenum. The final impression was follow-up of corrosive ingestion as described.
No, that's okay. So now what is your interpretation from this endoscopy?
Sir, she has
injuries what the patient has. Yeah.
Sir, she has injury both to esophagus and stomach, but predominantly the stomach is more appears to be more severely affected than esophagus. Esophagus, there are two strictures at 18 centimeter and 30 centimeter, but since it is easily negotiable, so it can be managed. It appears to be.
It's not easily negotiable, but they have negotiated.
But yes, sir, they have negotiated it, so it can be managed endoscopically. But as far as its stomach is concerned, sir, it seems to be more severely affected, and we would like to know whether it is salvageable in any way, and what is the condition condition of the stomach, sir, after 2 months.
No, so with this, the patient has got injury to the. In short, patient has got injury to the esophagus. Okay.
Yes, sir. Yes.
Patient has got substantial injury to the stomach.
Yes.
And patient has got substantial injury to the duodenum. Is it not?
Duodenum.
The long stricture in the duodenum. That's what it is.
Yes,
is the report is.
Yes.
So patient has confidently taken quite a lot of corrosive. Yes or no?
Yes, sir. Yes, sir.
What is the dictum as far as alkali and acid is concerned? Where does the alkali produce injury and where does the acid produce injury?
Sir, there's a dictum that acid licks the esophagus and bites the stomach, but it's not universally true, sir. And
but still, acid is little thin, so you can see here. Na? You see, the esophageal injury is little relatively less.
Yes.
And the gastric injury is more, and the duodenal injury. That's very surprising that duodenal injury also the patient has got.
Yes.
All right.
Yes.
So, do you have any other report to show? You have some pictures, no?
Sir, this was not done at our center, sir. This was done at 5 weeks of injury, sir. And in fact, the images are also not.
What is there?
Sir, there is a dilatation.
As far as the esophagus is concerned, how does it look?
Sir, there is mild dilatation of the upper esophagus, and there is a constriction which is seen at the mid esophagus level, sir. And in the last image, the fundus appears. It doesn't appear to be normal, sir. Although we don't have the full images of the stomach. But the fundus appears to be deformed, sir. It appears as a dumbbell-shaped esophagus.
Okay. It appears to be?
Sir, there is a slight constriction, sir, giving it dumbbell.
That's all. So, but what is very important here is, that the esophagus at least doesn't look strictured, is it not?
Yes, yes.
Grossly strictured, except for what you said, one minimal area of narrowing which is seen,
No.
is it not?
Yes, yes,
If you see up to the post-cricoid region, post-cricoid, it's not, the picture is not clear, so we don't know what is the status there.
yes, yes.
And the lower end is not very much seen, as you said, the stomach and all that is not very clearly visible.
Yes.
So, any other pictures there?
No other pictures, sir.
Fine. So now let us go back to the 8 weeks thing. What next? Now you're a treating clinician. That is the finding. What will you do next?
Sir, so we have to counsel the patient that she will ultimately require surgery. But as far as the timing of surgery is concerned, presently she has a poor BMI. She is poorly nourished because of a prolonged failure of enteral nutrition. We would like to create a portal for enteral nutrition. We would like to do a feeding jejunostomy for a patient, build up her nutritional status, and then subsequently take her up for a definitive surgical management.
Okay. Fine. I agree with you that the first thing you should think of in this patient is FG, is it not?
Yes.
So
yes.
FG has to be done now at this stage because there is no FG.
Yes.
So you do an FG in this patient, access and enteral, but anything else you would like to do? You can stop this thing, presentation. You shut the presentation. Yeah. Anything else? Now see, it is 8 weeks following injury. Is there any role for putting a nasogastric tube? Because the esophagus is patent. And why? Would you put or will not put?
So since the duodenum is also strictured, so it won't be very useful to put a nasogastric tube in this case, sir.
Any other view from anybody else? See, if I were in your place, I'll definitely put a nasogastric tube. It's not for feeding at all. The nasogastric tube is basically to keep a patent channel. As far as the esophagus is concerned, it still has injury at two places. You have a stricture at 18 centimeters and you have a stricture at 30 centimeters. Is it not?
Yes.
So when a patient has injury this type, okay, when a patient has injury this type, in those circumstances, we should definitely, in those circumstances, I feel that is what we used to do, that we'll put in a nasogastric tube and keep it. So that only one disadvantage is of nasogastric tube, that it produces a little degree of reflux, so that you have to take care. It's always better because if the esophagus proxy, can you give this patient oral?
No, sir.
No. So when you can give the patient oral, nasogastric tube may not be, because that fluids what you are giving orally will keep the patency of the esophagus. But once you put a FJ, everything will stop. You're not going. Otherwise, also, I don't think the patient, whatever the patient is taking little bit now, that will also be stopped. And the patient has got a narrowing of the duodenum and the stomach injury. So there's no point doing that. So just keep a channel there. So that if you have to pass a guide wire, we do not know what will happen to the esophagus. If the esophagus goes for a progressive injury and you need dilatation, then how will you carry out dilatation if it gets completely obstructed? It will become very difficult. The rise tube will actually give you a passage there. So two things we can do it, FJ and pass in a nasogastric tube for the subsequent dilatation. Now, you said you will program the patient for surgery. So subsequently, when will you assess what should be done for the patient? Next. Now he has come for 8 weeks, you have done FJ. When will you call the patient next?
Sir, ideally, sir,
Yes.
the strictures, they tend to stabilize after 6 months of injuries.
Okay.
So we have a 4 months time when we can build up the patient. We can call the patient one time in between to see whether she is tolerating FJ, whether she is gaining weight as per our expectations. We can advise her on the proper FJ feeds if she's or the dosage if we do not find her progressing expectedly. And then at 6 months, when she's in a better physical condition, we can offer her surgeries.
Would you not like to do any other investigation when the patient comes for follow-up? In another 2 months, maybe you'll call it 3.5 or 4 months.
Sir, since we'll be doing a FJ, we'll get an opportunity to assess the condition of our stomach also. So we will know.
No, that is at 8 weeks. Is it not? From outside, very difficult to assess the stomach. So injury is from inside.
Yes, sir.
So what is the harm in doing endoscopy? When you call the patient for follow-up. That is why we kept the rice tube there.
We can do. We can.
We
repeat
should.
the
We
endoscopy.
should. Would you
Yes,
not like
we
to
should.
know what is happening to the esophagus after another 6 or 8 weeks?
Yes,
Two things can happen. It can remain the same, or it can progress. If it
yes,
has progressed now and a full-fledged stricture has formed, why do we wait for 6 months?
right, sir.
No, why do we wait for 6 months? You said no, 6 months for surgery or a little later.
Yes, sir.
What's the reason for that?
So it's because of the progression of the stricture because it's a kind.
Progressive nature of this disease.
Yes,
Progressive nature of this disease. Progressive nature of this injury. That is why we have to wait. The complete injury should be established. Is it not?
yes,
If the injury is not established and halfway through you do some surgery and all that, and then you find remnant also there is something happening, then what will you do? That is why we wait.
right.
So at least for 6 months. So when you are waiting, you have to assess. So esophagus can go two ways. Either it can go for progressive stricture. The stricture is so bad, even if you have kept a rice tube and you find the moment you remove the rice tube, the whole thing is stricturous, long stricture is there. Or else you find it is the same thing at 18 and 30, minimal stricture is there, okay? And if you just put a balloon, you can nicely dilate it. Two options, okay?
Yes.
Then you assess the stomach can wholly become contracted. Or the rest of the stomach after 8 weeks might become alright and there is only a pre-pyloric stricture. Is it not?
Yes,
Possible.
yes.
So that assessment you will do with subsequent endoscopy. See, contrast is a problem in this patient because this patient has got lots of injuries. Is it not? Duodenum also is injured. So we don't know whether if we give a contrast, it will go down or it will not go down. Okay. So that can become a problem. So with endoscopy, you can do an assessment. And complementary contrast study can be done SOS in this patient. So you have done these things. So if there is a pre-pyloric sort of injury, rest of the stomach is normal. Normal means like it has reasonably become all right. And the esophagus is fine. Esophagus is fine means you have minimal stricture and it is nicely dilatable. And the duodenal injury is there. Okay, you can't enter the duodenum, and again through a fluoroscopic guidance and all you have done, and you find that there is narrowing. What will you do next? This is at 4 months.
Sir, sir, at 4 months, if we assess that the esophagus is manageable with endoscopic dilatation, and she is nutritionally
Nutrition is improved. You have put an FJ. Yes, weight
Then-
has increased. The BMI has gone to 19.
we can do a resection of the pylorus with Billroth 1 reconstruction. Sir.
No, no, not at all. Why no? When will you do and when will you not do?
I'm not aware. Sir.
See, this patient has got extensive duodenal injury. Will it help Billroth 1?
No, sir, it will not. Sir.
So, you will only do that Billroth 1 injury and tackling of Billroth 1 or what you said, Billroth 1 gastrectomy for a pre-pyloric stricture when the patient's duodenum is absolutely fine. As I told you, most of the time the duodenum is fine. I really don't know how and why this patient, or why the duodenum is scarred. It's very rare for so much of injury in the duodenum, but once in a while it can happen. So
Yes.
that's why I said it was a little tricky question I had put that in this particular patient, because of extensive duodenal injury, it's a long stricture. That's what we have seen, and that has progressed. I told. So irrespective of the gastric injury, there is no point doing any surgery on the stomach. Okay. So that is what is going to happen in this particular patient. So in this particular patient, that is not going to help. That is not going to help. That is a limited resection. What you're saying. So you don't do anything, you just wait and watch and let 6 months pass by. Okay, the patient's on GJ feeds. 6 months you assess and you find that stomach has got antropyloric scarring, okay, substantial scarring.
Yes.
And through duodenum also you can do a CT here and see that duodenum also is very much scarred, and the esophagus is manageable. Esophagus is manageable. So now, what will you do? Now you tell me what surgery will you do in this question. Esophagus is dilatable. What I mean is,
But sir, if antrum is also involved, then
duodenum is involved, antrum is involved, and the esophagus is dilatable. That's it. Esophagus dilatation done. Lumen is restored. How much usually dilatation is done when we do? Till what size we can go?
sir, 15 mm is
18 mm balloon is also there. Okay, so
yes.
But what is the cutoff to eliminate dysphagia?
So 13 to 15 mm.
14. Yeah, 14. What you said, 13 to 15 is correct. So if you can dilate up to 15, it's fine. It is dilatable. 6 months is dilatable to 15. What surgery? And when will you do?
So we'll do polio reconstruction, sir, for this patient, sir, at 6 months. We'll do
Polio entails a gastrectomy, is it not?
Yes, sir, it does.
So you have got a post pyloric stricture. So you would like to, the duodenum is also scarred. So you have to do resection. Why not GJ?
So because the antrum is also involved, and if we do a
GJ proximal to that,
so it could be a non-dependent gastrogynostomy, might not work for the patient and the patient's condition.
Whenever there is an antropyloric growth for carcinoma stomach, don't we do GJ? So you should tell that first. You should tell that first, that if the stomach has got a dependent thing, that is the first thing.
Yes.
And we have never presumed. We are saying without assessment. We are presuming it will not be there. Easier operation would be GJ. Yes or no?
Yes.
Now, the next question I'm asking, when will you do the GJ and why?
So we will do GJ after 6 months.
No. Why not? You should not. If you are planning GJ.
So we will do GJ only if we are sure that we will not be using stomach.
No, stomach cannot be used. No, the stomach is gone in this patient. No question of use of stomach for anything else in future.
So if we are sure that the injury has stabilized and is not going to progress any further.
That's the catch. Yes, you're correct. You're on path. Can you decide that at 6 months now? Difficult. 6 months is just borderline cutoff.
Yes.
So if I have to do a GJ in this patient and I'm planning, I might consider doing a GJ. Is it not?
Yes.
You can even do a contrast study to find out whether it's dependent or not. Is it not? The stricture, how much is it? If you find that there is a likelihood of a GJ passing through this patient, you have to be very, very sure that the esophageal injury will not progress. Yes or no? That's what you mentioned.
Yes.
If the esophageal injury progresses and you have done a GJ, it will be very difficult to do a colonic bypass. Yes or no? Because you have gone into supracolic compartment, anticolic, anterior GJ will do. Is it not? So you are crossing the transverse colon and then going through that. It will become a messy thing for you. So if I were you, what I will do is I will not decide anything at 6 months. And I know this patient has got a very unusual type of injury, that the stomach is also injured and the stomach is also fibrosed and the duodenum is also fibrosed. No harm in waiting for another 2-3 months. Absolutely no harm. The patient is on GJ for a few months, 4-5 months. The patient can be on GJ for another 3 months. No problem. Assess the esophagus again. You find progressive injury in the esophagus. Let's say progressive injury in the esophagus is there. Upper stricture is dilatable, but lower down, later on at 8 or 9 months, patient develops a long stricture. What will you do? What should be the next step? You understood the scenario?
So could you please repeat, sir?
Yeah. See, you have, I said we'll wait for 8 or 9 months. Yes. At 8 or 9 months, you have seen now that you are thankful to yourself that you have waited. You find that the proximal esophagus is fine, that 18 centimeter stricture is nicely dilatable, but the lower stricture has progressed and there's a long stricture now lower down, okay, and difficult to dilate. You have tried one or two dilatations and the patient is not comfortable. Patient is coming every week and the patient is having a stricture there. So, what next?
So we can do a
Again, you
partial.
can wait for 1 or 2 months, okay, because it has progressed.
Yes.
You can go up to 1 year, there's no problem. And now you see that the injury is stabilized. Let's say at 10 months, injury is completely stabilized. So proximal esophagus is fine, distal esophagus is strictured, gastroenteropyloric stricturing is there, duodenal stricturing is there. What surgery?
Sir, we can do a distal esophagectomy, sir. And
No. Who does hysterectomy for corrosive stricture? I'm not saying who does, but what I mean is like in this sort of patient, we do consider that. Isolated stricture of the esophagus, you can use a gastric conduit, then it is fine. Posterior intestinal, you put the stomach there. Yes, so much extensive injury is there. Only esophageal dissection is not enough. What about the stomach? Duodenum. It's not a difficult question I'm asked. So you just think over and you should be able to answer. Up till now, you answered quite well. Just imagine the scenario. You have a distal stricture. You have a distal stricture of the esophagus, distal stricture of the stomach, distal duodenal stricture, D2, D3. So what is the best way?
sir,
Anybody else
we can
also can
do
answer?
a mid colonic pull-up for this patient, sir. We'll bypass the esophagus and the stomach and the strictured duodenum. We'll pull up the colon and we'll do a esophagocoloplasty in the proximal, and in the distal we'll do a we'll anastomose the colonic conduit with the jejunums.
Perfect. That's the answer. A very simple answer. You do a esophago colonic anastomosis, okay, retrosternal, okay.
Yes.
And then down you do colo-jejunal.
Yes.
Bypass everything, no question of any resection. Whatever, let it happen to the esophagus later, let it happen to the stomach. Please bother. Because see, you will salvage the stomach, what you said, gastrectomy and all those things which can be done, considered. Okay, it's not that distal partial gastrectomy cannot be considered. When the duodenum is fine. Here the duodenum is also gone, no? Long stricture.
Yes.
Can you do resection of the duodenum?
No, sir.
It will entail to something like Whippleson. Are you going to do Whippleson in this patient?
No, sir.
No, absolutely not. So that's what I said with the first GJ at 6 months. You should be very wary in taking it up, because if you do a GJ, it might appear very simple, and then later on, the 8-9 months, the patient goes for stricture of the esophagus. It will become a major problem for the patient. If the patient still has at 8-9 months a nice dilatable stricture of the esophagus, then what will you do? The esophagus is now stabilized. It doesn't require a bypass. It doesn't require a resection. Nicely dilatable. At 9 months, it is dilatable. 10 months, it is going to stay like that, and you can manage it. Then what will you do?
So we'll spare the esophagus, sir, and we will do.
Then we'll do GJ. I said, okay. That time, gastroenterology.
Yes.
Why do polio and all those things? See, once you do a distal gastrectomy, you have to close the duodenum. Is it not? What will you do with the duodenum? Is it not? Yes. So you have to do that. Huh? So you have to go into the scarred duodenum, try to close it, and there is a likelihood of some problem, blow up, all those things. So those are the problems. So simple GJ will take care of it. It's not that GJ cannot be done. Okay?
Yes.
So GJ, the only problem is that subsequent esophageal anastomosis, esophageal bypass is required. It can come in the way. That is why we don't prefer. There are people who do GJ for prepyloric stricture also. It's like that.
Yes.
So that is how it will be done in this particular patient. If this patient has a very high stricture, like 18 centimeters, let's say the 18 centimeter stricture progresses. Okay.
Yes.
The lower stricture is fine. Okay. But the proximal one progresses. Then what will you do? It will progress, it becomes long fibrous. The moment you pass the cricopharynx, you just find a stricture there. So you can't do a bypass then. For bypass, you require proximal 5 centimeters of the clear esophagus. Is it?
So then we will do it in a phased manner, sir. We will first try to dilate the stricture below the cricopharynx and achieve a length of at least 5 centimeters of
If it is
esophagus.
dilatable, very good. If it is dilatable, if it is
Yes.
dilatable, you try like that. And if
Yes.
you find the lumen is still very narrow and things are a little bad,
Then we'll be left with no other choice. So then we'll do a flap surgery. We'll either do a pectoralis major flap or we'll do a
fine. I think you read our papers and then you're telling from that, is it not? So,
Yes.
so yes, you'd like to try to create a lumen as far as possible and get a proximal 5 centimeter lumen. If it is just not possible, then we do a pharyngocoloplasty. Okay, that's the last resort. So, why we are so hell bent on creating a lumen?
Sir, because pharyngocolic anastomosis has got a very poor functional outcome, sir.
Yeah. And an aspiration, is it not?
An aspiration.
So in this patient, the trachea is absent, I mean, the cords are fine, is it not?
Yes.
This is not going to have permanent tracheostomy. So if something like that is there, the respiratory passage is relatively fine, then you should try to create a proximal 5 centimeter of the esophagus. Okay.
Yes.
I think you have done well. Our time is up. We'll just keep 5 minutes for some questions. Okay, you can also take. I will also take. Okay. Can you answer the question? Can you see that? There are some questions there. One or two.
Sir,
for FJ, it would be helpful for future GJ if slightly longer segment of it left proximal to the FJ. Okay.
Sir, if a slightly longer segment is used for creating a FJ, we can use this FJ later on. After our subsequent reconstruction, we can use the same FJ for.
Can be done, okay, but we have not usually done like that, okay, but maybe possible, okay. First of all, we very rarely do a GJ. So, as I said, this sort of patient is very unusual where duodenal injury is there. So, if at all it's required, but very rare, this sort of injury. So, usually GJ is not the option. So, but can be done, okay. So, esophageal anastomosis, how it is done? End to side or side to side? Okay, can you answer that? End to side or side to side?
Sir, it is always preferred to do a side to side anastomosis so that we have a capacious anastomosis and less chances of stricture. Yes.
Definitely, you can do a stapled or handswing anastomosis. Earlier, we used to do end to side always, but now we are doing side to side. Since esophageal complete stricture is lower and in this, okay, side to side anastomosis, definitely. Okay, that will also prevent the formation of esophageal seal if there is a lower end closure. Okay, should we do total gastrectomy for scarcity along with esophagocoloplasty? No, not at all. I don't think that is necessary. And incidence of malignancy is very less. So, if the stomach is gone and we are going to do a bypass, then those circumstances do what just now Siddharth has told, to do a colojejunal anastomosis. What is the role of when will you do total gastrectomy, Siddharth? What is the indication for that? Total gastrectomy indication.
Sir, in this scenario, after a corrosive injury,
corrosive injury, I'm saying. Indication of only total gastrectomy as a part of treatment.
Sir, if this esophagus is completely all right and only stomach is scarred and it's a grade 4 gastric injury, the stomach is completely unusable for
scarred. Okay,
scar. Even then, sir, it's not necessary to do a gastrectomy. We can still leave the stomach in situ and then bypass the stomach.
How will you bypass it? No, the stomach is completely scarred. Okay, the esophagus is fine. But then, what is your proposed anastomosis? You have to do some reconstruction. No? What will you do?
So I'm not very sure, but can we do a esophagogynostomy?
How will you do side to side?
Sir, a roux construction.
So roux limb, the proximal stomach has to be excised, no? Then what? You just close it and keep it. If you close it and keep it, what will happen? Can lead to gastrocele.
Yes, sir.
Is it not? The scarred stomach. The distal end is also closed, proximal end also closing. So that is an indication for total gastric.
Oops.
If you have a extensive injury to the stomach and as you said, the esophagus is fine, You do a total gastrectomy, close the duodenum, and then do a end-to-side esophagogestomy. End-to-side
Yes.
usually we do it for all types of anastomosis, all gastrectomy. For malignancy also we do end-to-side. Same thing here we'll do. That is the indication for total gastrectomy. But again, that is not very common. Why? Can you tell me why? Very rarely we do this sort of surgery.
I'm not aware.
See, can it happen that the patient has swallowed a corrosive which passes through the esophagus and extensively damages stomach and spares the esophagus?
No, sir.
Very rare, no? Hypothetical condition.
Yes.
Very rare.
Yes.
I'm not saying hypothetically in our series we have found very few patients, but extremely rare. In 100 patients, you will find only 1 or 2 like that. Where the esophagus is complete. Why the esophagus is completely spared and the stomach is completely destroyed? Will it happen like that? Unlikely.
No,
No? Same. Because the esophagus, the corrosive has to pass through the esophagus. So that is why. But in case if it happens, it's a dilatable stricture of the esophagus and the stomach is bad. In those circumstances, you do consider doing a total gastrectomy. Okay. So some more questions are there. Will cytosine create a sump syndrome with the esophagus lumen which is completely closed in the end? No, not so common. Okay. So we do a nice and wide this thing. We do a nice and wide cytosine anastomosis. And if the esophagus is scarred, it's very unlikely that the esophagus will be scarred in the absolute lower end. Apparent is also scarred, so you don't have much of esophageal lumen to have the collection for sump. So that's not common. What is the question is not clear. Bleeding also means what? That is not clear. Okay.
Sir, if only distal end is involved and the of the esophagus is only distal end is involved and the proximal appears to be all right. So can't we resect only the distal part of the esophagus and do a thoracic anastomosis?
Is he resecting in a stricture, fibrosed esophagus? Not. It has got very esophageal injuries also. So not very much conducive surgery, and then doing intrathoracic anastomosis around. If at all resection is done and the anastomosis is done, then it's the neck anastomosis. We do a esophagotomy, pass the stomach if it is fine, or use a colon in the posterior mediastinum and do a anastomosis in the esophagus and down with the stomach if you are using colon. Otherwise, use only stomach, like we do it for THE, transhiatal esophagotomy for cancer.
Yes.
Thoracic has not come anywhere, anybody doing that sort of surgery. Any other questions? Tracheostomy, fistula, stenting, otherwise then you have to consider section. If it is manageable with stent, fine. If it is not manageable, then if it is very extensive, then you have to consider doing resection of the esophagus, a bypass of the proximal segment, and tackle the thoracic, the trachea. Call the thoracic surgeon, ask them to tackle the trachea. Again, very rare. I don't think we have come across any TO fistula. Very rare, extremely rare.
Good morning, sir. I have a doubt. If there is a isolated distal esophageal stricture, the proximal esophagus lumen is normal, and we plan for a gastric bypass, retrosternal gastric bypass.
Gastric bypass means?
Sir, there is an isolated non-dilatable distal esophageal stricture.
So you mean to say stomach is fine? Stomach is fine?
Yes, sir.
Okay.
And we plan for a retrosternal gastric pull-up.
Okay.
And we've done a side-to-side anastomosis. In that case, we'll do a side-to-side anastomosis or an end-to-side anastomosis in the neck. My concern is regarding.
Actually, I don't have much experience with this. Okay. If you ask me, we would do a chronic bypass. Okay. Do not touch the stomach here and do a colon. Because as I said, this is again we are creating some hypothetical situation that lower end of the esophagus is extensively scarred, requiring bypass, and stomach is completely spared. It's unlikely, no? This sort of thing scenario. So I think there will be some injury in the stomach. So better not to scratch the stomach and do a bypass, chronic bypass. So what you do is you do a colonic bypass, and lower end of the colon, you do a cologastric anastomosis. That's what you do.
Okay, sir. And in the neck,
Better.
we'll do, in the
Side
neck,
to
we'll
side.
do side to
Side to
side.
side. Yeah.
How,
Esophagus
how,
we don't touch. We just make a incision, longitudinal incision along the length of the esophagus, around 5 centimeter. And then what we do is that mid colon, what we take, okay, coloplasty, what we leave behind part of the colon little bit more proximal, so that if a stricture develops, that can be used for re-anastomosis later. Little bit, 3-4 centimeter, we leave it, and then do bypass. Am I clear, or shall I share the board?
Thank you, sir.
Okay, the board can, and who's operating this? If you can share the board, I can tell exactly. I can show what is done. Who's operating this system? So, can you enable sharing? Is it done? I don't think it's done. Okay, I hope you understood. Okay, Dr. Lokesh, what I said.
Yes,
So,
thank you, sir.
yeah. Any other queries? Any other question?
Good morning, sir.
Good morning. Yeah.
Sir, Kulbhushan sir from
Yeah.
Nims Hospital.
Okay.
Sir, I would like to give you sir comment, sir. One of the student asked regarding ligation of middle colic at the time of abscess. I think he was he want to ask regarding pre-operative ischemic conditioning, sir. In which like few studies suggest during gastric pull-up, if we ligate or embolize left gastric before the gastric pull-up, that is based on the right gastrophloid, that in that scenario the vascularity of conduit is good and there is a less chance of anastomotic leak. In same scenario, sir, if in the colon, if we ligate the ilocolic, not the middle colic, at the time of abscess, in that scenario, sir, the right colon that is based on the middle colic. So the vascularity of conduit is good and there is a less chance of anastomotic leak, sir.
No, see, when it comes to stomach, okay, you have only one stomach, is it not? When you have colon, this right colon, mid colon, left colon.
Yes, sir.
So what we usually do when we mobilize the colon, we put a vascular clamp on these vessels. Okay, we don't consider doing angiography and all the things. Mobilizing takes long time, is it not? You put a vascular clamp, a bulldog clamp. Okay, right colic, we usually use a mid colon coloplasty. So what we'll do is we'll put a bulldog on the middle colic and we mobilize. Two things can happen. That is putting a bulldog, the part of the colon which is supplying. Okay, arcade you have to preserve. It's absolutely fine.
Yes,
okay,
sir.
if it is absolutely fine means what? Then you are free to ligate middle colic. If it is not fine, then you don't ligate the middle colic. Okay, that is what it is. So that is how. Right colic brother also, like in case if you are going inside and you find the right colic circulation is precarious and you want to do a right colon based coloplasty, don't do it. Do left colon based. All vessels will not be bad. No? It's like that. In the stomach, there is no other option. That is basically done to preserve the fundal blood supply. Okay. Here it's not like that. You can base it on right colic, you can base it on middle colic, you can base it on left colic. Three options are there.
Yes, sir.
Very unlikely that all the things will be bad. If all the things will be bad, then you have to consider doing a free jejunal flap. If the stomach is not there. Like that. Okay.
I have one more doubt, sir. So, what is the role of CT scan of the neck and chest in the management of high corrosive esophageal strictures, sir?
You see the lumen, air.
Okay, sir.
When you do the CT, okay, endoscope cannot pass, you cannot judge. Contrast patient will not swallow. So you do a CT, and if you find, say patient swallows air, na? So if you find a channel of air, okay, so there is a stricture of 1.5 centimeter. Beyond that, you have a channel of air. If you have a channel of air beyond that, then you know that when you do a, let's say, a flap cover. Okay, how flap cover is done? I really wish that board is shared. Why somebody not sharing that board? Okay, that how do you do the flap cover? Okay, you open the esophagus. When you open the esophagus, proximal esophagus, if air is there demonstrated on CT, you will find a lumen. Once you find a lumen, you put a flap. Sternocleidomastoid mastoid flap is next to it only. Okay, so that myocarditis flap you put and then create a lumen and then dilate it. Once you have a dilatation and you created a lumen, you have a 4-5 centimeter proximal esophagus, new esophagus generated. That is the aim of doing the CT.
So can you please try sharing it?
Okay, sir. Thank you, sir.
Yeah. So this is the whiteboard. Share. Is the board visible now to everybody? Must be visible.
Yes, yes.
Yes.
So now what we do is basically like I've drawn a esophagus. Okay, it's not looking strictured, but I'm going to create a stricture now. Now let's say the stricture is here like that. Okay, like this. Now here you can't pass the endoscope; it's tightly strictured. But when you do a CT, okay, and this region, okay, you find there is a air column like this on CT. CT will show the air column. Now this air column is there. That means what? The upper part is stricturous, but beyond that there is a lumen. So what do? You go through the right side of the neck, because left side will use it for coloplasty. Open the esophagus, that area, and then you try to open this channel. So once you open the channel, you'll find the esophagus like this. It has got a lumen here, and this area it is strictured. So this area also you cut through, okay, and open it. Once you open, you take a sternocleidomastoid flap, the skin part inside. Remember, the skin becomes the mucosa. This is the skin part, and this will be sutured here. So what will happen in the cross section? The lumen was like this. Okay, you have opened it like this, and now you have put the flap here. So the total lumen will become. Total lumen will become like this. Okay, it may not become so big. It will be initially very narrow. Then you have to keep on doing serial dilatations, and then generate a lumen, which is good. Once you have got a lumen of 15 mm, go through the right side. Like this is the neck. And this is the sternocleidomastoid, you see, and then you give incision on the right side and approach the same esophagus from the right. So no fibrosis is there. This side you have done all the surgery, flap cover and everything, and now you have a new esophagus which is created. So the new esophagus is here. In that you put a side to side colon. This is the colon. So we do a side to side anastomosis like that. And I said that we keep little bit of colon here extra. So suppose this becomes strictured overall later after some time, you can use this colon itself to mobilize and do a anastomosis in the neck. So you don't have to do a fresh surgery or anything. That is what I said. Little bit we keep. Too much will produce a swelling. So that's a side to side anastomosis. To prevent stricture, we have to be very sure that the lower end of the esophagus which passes into the neck, it is very open and free. One of the causes of stricture is ischemia, because the colon goes on the mesocolon and the mesocolon gets compressed in the neck. If the mesocolon gets compressed in the neck, it leads to ischemia of the anastomosis, and that leads to stricture. So we have to make sure that that is not there. That is one of the commonest causes. So we should avoid that. Any other question?
Thank you, sir.
Any other clarification? If nothing else is there, then we can stop. Okay. So again, very good presentation. Okay. Corrosive stricture is not easy to present. Okay. So don't see many centers don't do it on routine basis, so they don't see all types of injuries. And you have prepared it very well, and there was not much inputs I had to give from my side. So very good presentation, Siddharth, and good discussion by all. So if there are no further questions, I'll wait for one more minute. Then we close. We didn't have time to cover the complications of surgery and all those things, but then you can read from. So you can have cologastric anastomosis stricture. You can have delayed gastric outlet obstruction. So all those things can happen. In the acute phase, you can have conduit necrosis. But the answers for that are given. Okay, fine. I think no further questions. Then shall we close?
Yes.
I will leave. Okay.
Thank you, sir.
It was good to interact with you.
Thank you, sir.
I'd like to thank Dr. Kapoor for this opportunity, and it was very nice interacting with you all on this. Thank you very much, Professor Kapoor.
Thank you, sir.
Thank you.